Welcome to your most favorite channel, Heartbeat. My name is Dr. Kejriwal. This channel is mainly meant for MBBS students, postgraduates, medical professionals, and all those who may find it a bit more easy. It is an attempt to make the complicated medical sciences more simplified and easier for understanding.
Today we will study something about hypokalemia. Hypokalemia is commonly seen in the OPD patients and IPD patient, and it contributes significantly to cardiovascular morbidity and mortality, and therefore the diagnosis and treatment of hypokalemia is of prime importance. Channel's name is Heartbeat. My name is Dr. Kejriwal. By definition, plasma potassium is less than 3.5 milligrams per deciliter. Hypokalemia, it affects the blood pressure, cardiac rhythm, and cardiovascular morbidity. All these contribute together and increase the mortality in hospital. So, the treatment of hypokalemia is of prime importance, which directly affects the heart and the blood pressure. Coming to the etiology of hypokalemia, it can be due to various causes: decreased intake and absorption, redistribution into cells, which is again due to various causes, increased loss. Increased loss can be divided into two types: non-renal loss and renal loss. Non-renal loss refers to the loss by skin or GI loss, and renal loss means loss by kidneys. So there can be different mechanism: increase in distal flow of and distal delivery of sodium, or increased secretion of potassium. Increased secretion of potassium can be due to various causes: mineralocorticoid excess, apparent mineralocorticoid excess, or distal delivery of non-reabsorbable ions. And there may be also magnesium deficiency. In the same patient, there may be multiple causes of hypokalemia, each aggravating the other. So sometimes you have to treat both the causes simultaneously. Now coming to the decreased intake and absorption, it can be due to starvation or clay ingestion. Redistribution into cells, that is the cells uptake the potassium, commonly seen with insulin, which can be exogenous or endogenous insulin. Increase in the beta adrenergic activity. Increase in beta adrenergic activity can be seen in various conditions such as alcohol withdrawal, acute MI, head injury, bronchodilators, and cough syrups. Thyroid hormones. These also cause hypokalemia, commonly seen with thyroid periodic paralysis. Metabolic alkalosis is another cause for the distribution of potassium into the cells. Anabolic states. Now a patient comes to us with megaloblastic anemia or has bone marrow aplasia, and you give him vitamin B12 or folic acid supplementation, and in some patients you give GM-CSF stimulation, or patient may require TPN. In this kind of patients, there is rapid generation of cells, and the potassium in the cells increases, and they may precipitate a decrease in the plasma potassium. There are other causes of hypokalemia also, such as pseudohypokalemia, hypothermia, familial hypokalemic periodic paralysis, and barium toxicity. Coming to the non-renal loss of potassium, mainly from the skin or the GI tract, such as vomiting, sweating, and nasogastric aspiration. These lead to hypochloremic alkalosis due to dehydration, and the dehydration with hypochloremic alkalosis leads to secondary hyperaldosteronism and bicarbonaturemia. This secondary hyperaldosteronism and bicarbonaturemia leads to caliuresis. Other causes of non-renal loss of potassium, such as diarrhea, mainly infective, or non-infective causes of diarrhea, such as celiac disease, ileostomy, villus adenoma, vipomas, and chronic laxative use. So these are some of the non-renal causes of loss of potassium. Renal losses. This can be due to the increase in distal flow and distal delivery of sodium. diuretics, osmotic diuresis, salt wasting nephropathies. Renal losses due to increased secretion of potassium, due to mineralocorticoid excess, various causes, primary hyperaldosteronism, aldosterone producing adenomas, adrenal hyperplasia, adrenal carcinoma, genetic hyperaldosteronism, secondary hyperaldosteronism, Cushing syndrome, Gentleman syndrome, and Bartter syndrome. Hypokalemia, it affects the blood pressure, cardiac rhythm, and cardiovascular morbidity. All these contribute together and increase the mortality in hospital. So the treatment of hypokalemia is of prime importance, which directly affects the heart and the blood pressure. Again, renal loss, increased secretion of potassium due to distal delivery of non-reabsorbed anions. Vomiting, nasogastric suction, proximal renal tubular acidosis, diabetic ketoacidosis, glue sniffing, penicillin derivatives. And one more, magnesium deficiency. This has to be seen and checked in all patients having hypokalemia. Coming to the clinical features, it has got a prominent effect on the cardiac, skeletal, and intestinal muscles. May precipitate atrial or ventricular arrhythmias, and this is very important as the patient can land into immediate mortality if it is not taken care of immediately. And patients who are on digoxin may precipitate digitoxicity. ECG changes may be seen, broad flat T waves, ST depression, and QT prolongation. There are other features that can be seen, renal, such as sodium chloride and bicarbonate retention. Patient may have polyuria, phosphaturia, hypocitraturia, and activation of renal ammonia genesis. Progression of hypertension, heart failure, and stroke may occur with hypokalemia. Approach to the patient, like all other illnesses, history, physical examination, and lab investigations. History: drugs, diuretics, laxatives, antibiotics. Look for the diet and dietary habits. Look if the patient is starving, has got taking clay ingestion. Look for history of periodic weakness and diarrhea. Coming to the physical examination, look for the blood pressure. Look for the volume status. Look for the deep tendon reflexes, and look for specific disorders such as hyperthyroidism and Cushing syndrome. These can be recognized clinically generally. Laboratory evaluation: do the complete blood count, do the electrolytes, do the BUN serum creatinine, do the serum osmolality, do the serum magnesium and calcium, do the urinary pH, osmolality, creatinine, and electrolytes. Now coming to the approach, do the history, physical examination, and basic lab tests. From this, we diagnose the serum potassium is less than 3.5 milligrams per deciliter. Is it an emergency? Patient has arrhythmias, prolonged QT syndrome, then start therapy immediately. If it is pseudohypokalemia, no further treatment is required. Coming to the same, serum potassium less than 3.5 milligrams per deciliter. If there is a low intake, you treat and reassess the patient. If there is intracellular distribution, we've gone through the various causes such as insulin or head injury or alcohol withdrawal example, you treat accordingly. Now coming after the history, physical and basic lab tests, other causes ruled out which have been discussed previously. Hypokalemia is there, serum potassium less than 3.5 milligrams per deciliter. Do the urinary potassium. It may be either greater than 15 milligrams per day or it may be less than 15 milligrams per day. If it is less than 15 milligrams per day, it means the kidney has the potential to conserve the potassium. So there is no basic pathology with the kidney. So do the acid-base balance. Patient may have metabolic acidosis, which means GI potassium loss. If it's normal, then it means the patient could be having something like profuse sweating, and the patient may have metabolic alkalosis, which is due to diuretics, sweating, vomiting, or nasogastric aspiration. Urinary potassium greater than 15 milligrams per day continued from the previous slide. Then it implies that it's a renal loss predominantly. Do the TTKG, transtubular potassium gradient. It may be less than 2 or it may be greater than 4. If it is less than 2, it means that there is increased tubular flow and this is due to osmotic diuresis. If it is greater than 4, it means that there is a distal potassium secretion increase. Check the BP and volume. The BP and volume may be high or it may be low. If it is high, do the aldosterone levels. Again, aldosterone may be high or low. If the aldosterone is high, do the renin. Renin can be high or renin can be low. If it is high, it is usually due to renal artery stenosis or renin tumors or malignant hypertension. If renin is low, then it's due to primary aldosteronism or familial hyperaldosteronism. Again, if aldosterone is low over here, then you do the serum cortisol. Again, serum cortisol may be high or low. If it is high, it indicates Cushing's syndrome. If it is low, it indicates Liddle syndrome, licorice, or syndrome of inappropriate aldosterone secretion. Now, if the urinary potassium is greater than 15 milligrams per day, renal loss, TTKG greater than 4, distal potassium secretion is increased, BP and volume low, then we have a different approach. Do the acid-base balance. It may show metabolic acidosis or it may show metabolic alkalosis. If it is metabolic acidosis, it goes in favor of distal renal tubular acidosis, proximal renal tubular acidosis, diabetic ketoacidosis, or use of acetazolamide. If it is metabolic alkalosis, do the urinary chloride. It may be greater than 20 or less than 10. If it is greater than 20, it means that it could be due to diuretics, Bartter syndrome, or Gitelman syndrome. And if it is less than 10, it means it is due to vomiting or diarrhea. And if the acid base is variable, then it means like an unknown anion such as hippurate. So we can see that there are various approaches of hypokalemia. Now coming to the treatment, urgency, digitalis toxicity, arrhythmias, and prolonged QT syndrome. These require urgent treatment and immediate management. Treatment, it consists for look for coexisting diabetes mellitus, magnesium deficiency. So if you treat the diabetes or magnesium deficiency, the hypokalemia may reduce. Preferred is oral treatment with KCl. If the patient has hypokalemia with hypophosphatemia, treatment is with potassium phosphate, oral or IV. And if the patient has hypokalemia with metabolic acidosis, treatment is potassium bicarbonate or citrate. And IV potassium supplementation may be given very carefully, especially in patients who are unable to take orally or if the patient has arrhythmias. So it is given in a saline solution at 20 to 40 milligrams per deciliter, and the femoral vein is preferred over the subclavian or internal jugular vein for parenteral potassium supplementation. Reason being, the subclavian vein or internal jugular vein, the catheter may touch the myocardium and there may be local rise of the potassium concentration precipitating arrhythmias, while in a femoral vein the chances of local potassium in the heart being increased is less. So that's all for today. Thank you.